Our first didactic session today is titled, How Will a Brain Tumor Diagnosis Affect My Mood? As you know, brain tumors not only affect brain function, but can also significantly impact emotions and mental well-being. This session will explore common areas of distress associated with a brain tumor diagnosis and discuss how to manage overall emotional and mental health to extend quality of life. We're very lucky today to have Dr. Ashlee Loughan as our speaker. Dr. Loughan is a clinical neuropsychologist, an associate professor of neurology, and the director of the Live Now Neuro-Oncology Wellness at Virginia Commonwealth University. Throughout her tenure at Virginia Commonwealth, she has steadily pursued a commitment toward improved brain tumors patients' quality of life, and her research interests include neurocognitive outcomes, psychological distress, and intervention development for enhanced well-being. We're also very lucky today because Dr. Loughan has invited one of her patients to join us and share her perspective. And the patient will be introduced by Dr. Loughan, but I thank the patient on behalf of the rest of the speakers today. And I think it's wonderful that we're going to have that perspective as well. Ashlee, we're so lucky to have you and your patient join us today. Thank you for being here. And please join me in welcoming Dr. Loughan and her patient.
Hi there. Can everybody hear me? Okay, great. Thank you, Dr. Castro. Thank you to the ABTA. I'm honored. I'm excited to be here. It's one of my most favorite presentations to actually speak to the patients and their families and loved ones. So I hope that I can bring some wisdom. I hope that you guys get stuff out of our presentations today. And after my presentation, I'm really excited to chat with one of my patients for her to share her story. So let's get into it. Okay, here are my disclosures. I am on the clinical advisory board for the ABTA, and my research currently is supported by Massey Cancer Center and the Department of Defense. So what I'm going to go over in my presentation today is what do we know to date about the emotional effects of a brain tumor diagnosis? And then we'll segue into how can we manage these effects that we're experiencing? And what are the next steps? Where is research going? Where is the field headed? And how can we participate? So what do we know? We know that psychological distress is high in all patients that have been diagnosed with a tumor. But our patients with brain tumors are actually at heightened risk. So given the location of the tumor in the brain, there's a direct impact of the disease and its aggressive treatments on the day-to-day functioning of our patients, which in turn affects their quality of life. For some, there is a high certainty that the tumor will progress or grow throughout the disease. And despite scientists' best effort, currently we have no curative treatments for most of our brain tumors. And unfortunately, to date, there is no standard of care for supporting our mental health in our neuro-oncology patients and their loved ones. So there are many reasons that our emotions, our mood, our psychological functioning can be disrupted because of a brain tumor and its treatment. So obviously the tumor itself is located within the brain. This impacts the circuitry. It impacts the way we might perceive things that are happening around us, but also it might impact our ability to manage, to cope, to respond to what we're perceiving. And then, of course, after brain tumor identification, the best line of defense is to remove that tumor. In doing so, though, the neurosurgeons, very skilled and crafted, have to cut into our brain circuitry. So there might be impact as a result of that. And then, of course, following, our patients undergo aggressive treatments directly targeting the brain and its circuitry. So we know that radiation, while it might keep the tumor at bay, through time causes scar tissue that again impacts the circuitry of the brain. And then chemotherapy. And a lot of our patients remain on chemotherapy throughout their disease trajectory. And chemotherapy, chemo brain, as a lot of our patients describe it as, it's a fogginess, it's a clouding of the thinking, which is very frustrating to our patients. And our research has actually shown that chemotherapy doesn't necessarily destroy the cognitive thinking, but it causes a person to work harder to produce the same functioning as they used to produce, which can be very frustrating, not only for the patient, but the loved ones who are trying to help them out as well. And then, of course, a lot of our patients are put on medications that also have neurotoxic effects that can impact their thinking and impact their mood, including the steroids and the anticonvulsants to keep the seizures at bay. So there's lots of reasons that our brain is getting impacted after diagnosis and throughout the treatments. So what we're going to talk about first, like I said, is what do we know about the psychological impact on our patients? What are the areas of distress that our patients experience? The first one that I hear often is depression. Nearly all of our brain tumor patients report some kind of symptom of depression, with clinical diagnoses being higher than the general population and higher than other tumor populations. So what does depression look like? Because it actually can look very different depending on the person. So some patients have a psychological response where they are sad, they might be increasingly tearful, or they explain that they just don't feel any joy in their life anymore. Other people have a behavioral response. They might spend more time in bed. They might, their appetite might reduce, and or the opposite, they might start overeating. And some become irritable and might lash out at those that they love. And then, of course, there's the cognitive symptoms of depression, which is the low self-esteem, the low self-worth, talking negative about themselves in their mind, and maybe talking negative about others. Now, we know that depression is associated with day-to-day impairments. It's hard to function when we are clinically depressed. It also results in cognitive impairments. Our patients who are depressed report slower functioning, processing speed, decreased attention and concentration, which results in memory impairments. And depression has been shown to be the #1 indicator of reduced life quality over and above tumor grade and or tumor aggressive treatments. So another area of distress that our patients report is generalized anxiety. This is not necessarily specific to the tumor and or its treatments. Generalized anxiety is an overwhelming sense of restlessness, worry, fear, thinking that the shoe's going to drop at any time. And up to a third of our patients actually report day-to-day moderate to severe levels of generalized worry. There are some risk factors that the literature has shown. So some report that younger female patients with lower grade tumors report higher level of anxiety. There is question of, are they actually experiencing higher levels of anxiety, or are they just the population that's more apt to express it and share that with others compared to their older counterparts and or males? And also the location of the tumor. So we've noticed that those with a tumor on the right side of the brain have a higher likelihood of expressing anxiety. But these symptoms tend to be transient, meaning they come and go, with heightened times associated with those MRIs or those scans, which this term is probably very familiar to everybody on this call, but my patients describe to me scanxiety, which is usually that 1 week or 2 weeks before their imaging where their stress and their anxiety is heightened before they go in for their MRI. And what is underlying that scanxiety? It truly is a fear of the tumor recurring or progressing or growing. Now, this is not uncommon. This is actually very common in all patients with tumors, and it's documented as one of cancer patients' greatest unmet needs in the psychological world. Nearly all of our brain tumor patients report symptoms of fear of the tumor recurring and or scanxiety. But again, like I said, it's common. So some people experience as mild severity, and this is actually normal and lessens through time. The more MRIs, the more you become accustomed to these feelings, you're able to manage and cope with them. But unfortunately, for about 30-ish, 30 to 40% of our patients, they report moderate to severe fear of the tumor recurring. And this can cause some maladaptive patterns. So it can cause you to avoid going in for your scans or talking to your medical doctor when you experience symptoms, and or the reverse. Some of our patients experience very high, what we call hypervigilance, which is any symptom that they notice, they attach onto and think that means immediately that the tumor has come back. Now, this is different than other tumor locations and or cancers. So for example, breast cancer or melanoma the breast cancer might touch and check their breasts to see if they feel a lump. Skin cancer might examine their arms or their legs or their torso. And our brain tumor patients don't necessarily feel around in their head to see if their tumor has come back, but they might get really worried if they have a mild headache that might just be seasonal or allergies. They start to count how many times they have had a word finding problem. And they become really hyper-focused on these symptoms that might have been the initial symptom that they experienced before they found out about the tumor. And of course, this fear can certainly grab a hold of you and can prohibit our patients from living meaningfully and also prohibit them from planning for an enjoyable future. And then finally, the last area of distress that I want to talk about is something called fear of mortality. And in the research world, we call this death distress or death anxiety. Now, again, this is common in patients with oncology diagnoses. About 32% of patients with cancer diagnoses, especially advanced cancer, report death distress or a death anxiety. Our brain tumor patients, almost half report moderate to severe levels of fear that they are going to die sooner than they had hoped or planned on. A preoccupation with this, it truly can halt somebody's day-to-day functioning. Our patients have decreased life quality that experience death anxiety. Some of them become non-adherent to their medical regimens because they're avoiding and they're concerned about actually communicating with their healthcare providers, and they overall experience poor health outcomes. What our patients report to me, our research has shown those that have a fear of mortality, a fear of death and dying happening sooner, are scared to miss those milestones. So for example, will I still be here to watch my grandchild graduate from high school, get married? Will I be able to see my first grandchild? Will I obtain that promotion that I've been working so hard the last 10 years for? And or the fear that they haven't done enough in life yet to leave the legacy behind for those that they love. And then I would be remiss if I did not also talk about our caregivers' mental health, because as we know, this diagnosis doesn't just impact the patient, it impacts those that love them. So caregivers immediately take on astronomical increased responsibilities. They are thrown into immediately monitoring the illness of their loved one. They have to communicate with doctors that include a ton of medical jargon and lingo that they have probably never heard of. They have to arrange appointments. They are providing the physical, emotional, and social support for their loved one, and also for everyone else that loves the patient. So they're kind of that barrier between the rest of the world and the patient, and they have to open and close that door as they see fit and as the patient can handle. And then also they're thrown into making some pretty serious decisions without much formal training. So to date, there again is no standard of care for training our caregivers. I know there are people that are working on it. You will hear from one of them later on, Dr. Forrest, but right now our caregivers are thrown into this role immediately upon diagnosis. We know that our caregivers experience a reduced quality of life. There is significant burden placed upon them in caring for their loved one. Though they're happy to do it, it is very challenging. And our research has actually shown that all of the psychological domains that I just talked about, depression, generalized anxiety, fear of the tumor coming back, and death distress, our caregivers report higher severity levels than actually the patient themselves, showing the need for us to be caring and providing support to both the patient and their loved ones. Okay, so next up, how do we manage these symptoms that we're experiencing? So, our physicians' first line of treatment for mental health still remains medication, antidepressants being probably the number one prescribed. Yet, to date, we still have no high-quality studies actually examining the effectiveness. But about a fourth of our patients with low-grade or benign tumors are put on antidepressants, after diagnosis, and nearly half of our patients with high-grade or malignant tumors are put on medication for their mood. Now, some patients report benefit from these medications, but I do always like to warn our patients before going on them that there are some contraindications. So it is possible that some of them might lower your seizure threshold. So it's always something to discuss with your physician before they prescribe to make sure that you are not at risk for that. And a lot of our patients report increased memory impairment, increased fatigue, and sexual dysfunction when on some of these medications. So again, I like to bring that up in my talk so that you are educated and know what to ask your physician before trying a medication for your mental health. Before I recommend medication, I always try to incorporate in with my patients some basic mental health strategies. Now, let me tell you, everybody on this call, this is not rocket science. This is what all of us, brain tumor, caregiver, or not, should be incorporating into our day-to-day life to help our overall well-being. The first one, exercise regularly. This is our natural way to help our physical functioning, to help our cognitive functioning, and to support improved mood and wellness. And I'm not talking about going out and running a marathon tomorrow. It's great that Dr. Castro can do that, but most of us can't. This is just going out for a walk, a brisk walk a couple times a week for 15 minutes. Just that alone has shown to increase our physical functioning, improve our memory, and support our emotional health. The second one, which was equally as important, is getting sufficient sleep. Now, this is a problem with our patients with brain tumors. About 60% of our patients report sleep disturbance. And that can, as you know, if you have ever had a poor night's sleep or, months or years of poor sleep, it can significantly impact our day-to-day functioning and our overall mood. There are non-medication ways that we can help get good sleep. Talk to your physician about it. Ask them about the programs or the specialists who can help us get good sleep. A full, good 6 to 8 hours is going to set us up the next day, set up our brain, set up our mood for success. Another thing I talk to my patients about is spending less time sitting still. So I challenge my patients quite often. How far from your bed, from your couch, from your house can you get this week? And I try to see if every week they can beat that. And that might mean for some just getting out to the front door. That might mean for some going to the mailbox. And for others who are able to drive, it might mean going to the store, mean going to visit a friend, might mean getting out of town. But how far can we get away from our bed and from our couch? Also getting outside. It is summer out. The sun is good for us after we put on sunscreen. Getting outside improves our mood and improves our day-to-day functioning. Another really important one, ensure we have positive support around us. Have people that are encouraging us, that are cheering us on, that are helping us attain all of these good mental health suggestions. Go out, socialize with your friends. It is one of the number one ways to keep our brain active and healthy while you're going through these treatments. And then, of course, engage in things that we like. I'm really bad at golf. I don't like golf. So that's not something I would choose. But I might go out and garden with some of my friends or go to a coffee house or listen to music. Find the things that bring you joy and incorporate them into your life on a day-to-day basis. Experience new things, experience new learning. Now is the time. My lab is called Live Now, right? I'm not talking about tomorrow. I'm not talking about 7 years down the road. Live today. Do something new. Experience something you've always wanted to. And then, of course, maintaining a healthy diet. Now, this can be complex depending on what treatments you are on. So always talk to your physician about what diet you should be on. But what I say is maintaining an overall balanced diet. Trying to eliminate as many processed sugars. It doesn't mean you can't have the ice cream, but maybe not eating junk all day. We are fueling our body and thinking of it that way instead of putting in things that are going to hold us down and weigh us down. Now, if these strategies, incorporating these, again, basic, everyday mental health strategies still aren't doing enough, you still feel like I am sad, I am worried, it is taking over my day-to-day functioning, that is when I usually say it's time to reach out to a professional. So the first thing you can do is see a mental health provider. And these are located at your hospital. If you are fortunate to be at a large academic medical center, a lot of community hospitals have mental health professionals, but also they are around in our general community as well. So ask your physician, do you have any neuropsychologists, clinical psychologists, counselors, or social workers at your hospital that you can talk to? Nurses are underutilized for this. They are the people that are frontline and understand what you are going through the most because they are day-to-day working with patients just like you. So talk to your nurse about what you're experiencing. If you are religious, go to your pastor, go to a clergy member. These are all people in our community that can help us out. And after you seek out a mental health provider, I recommend sharing with them all of the different symptoms you are experiencing. They are trained to figure out what it is you're experiencing and the severity. And that will direct them towards evidence-based treatment that we know helps with depression, that we know helps with fear of cancer recurrence or fear of the tumor coming back. Here is a list of evidence-based treatment options that have been used, again, with just general distress, but also with other tumor or oncology populations. Mindfulness is a really popular evidence-based treatment. And actually, a lot of our patients have told us that we've worked with mindfulness, that this is some of the strategies that they have incorporated and found the most beneficial in their day-to-day. So mindfulness can be basic relaxation strategies so that we can take back control over our thinking, take back control and relax our body. Deep breathing helps out with those acute episodes of distress. Again, right before we're about to enter that MRI, how do we relax ourselves and get our body in a state ready to go through that imaging? And then, of course, meditation, which some people think of meditation as sitting and staring or thinking of something for 30 minutes, hours. It doesn't have to be that. Meditation can be as short as a couple seconds, 30 seconds, a minute of refocusing, recentering, and being purposeful in our thoughts and in our actions. Cognitive behavioral therapy, CBT, is probably something most of you have heard about through life. It is kind of the hallmark of psychotherapy. So it is really identifying those unwanted or unhelpful thoughts, which lead to maladaptive behaviors and obviously poor emotions. And so it is helping identify those, adjust those thoughts, which lead to better behavior patterns and improved emotions. And then there's some other evidence-based treatments that are being studied and have shown successful. So direct attention training is learning how to focus our attention and direct it on will as needed. So sometimes we get in a rut and we're thinking of negative things, and it's being able to redirect our attention to something else, pull us away from those unwanted thoughts. And then goal management training is setting intentions, setting goals. And some of that could be, my goal is to get out of bed today. My goal is to walk out this week to the mailbox or take a walk 3 times, like Dr. Loughan said. And so it is helping set goals and meeting those goals and attaining those goals. So I put these on here so that you guys have some of these key words to talk with your mental health providers about, but also to even look them up online. There's some great resources online available that can help out in some of these areas. YouTube is a wonderful resource. And thank goodness for our iPhones, we have unlimited access to apps and websites. Okay, the last part before we get to our patient voice is next steps. So where are we? Where are we going? What does the field need to do? So thankfully, again, quality of life has become a topic in neuro-oncology, which hasn't always been the case. So a few years ago, my team set out to find the interventions or strategies that are most helpful for our patients with brain tumors. And we were searching for distress and what our patients were experiencing. And what we found was that out of 132,000 tumor or oncology patients that were interviewed, that were surveyed, that were treated for emotional distress, less than 0.2% were patients with brain tumors. This was jaw-dropping to me. And what it told me is that our patients actually weren't being included in this research, but there was a purposeful exclusion, an 8-fold underrepresentation, as 1.4% of cancers are brain cancer. So why were our patients being excluded? The number one is a blanket statement of no CNS disease is allowed to participate. The second, cognitive impairment. Now, this is understandable. Our patients absolutely experience cognitive decline where the tumor is located, and again, its treatments. And I think Dr. Harvey Jumper is going to talk about some of that next. But what we dug deeper and found was that the majority of these studies that were investigating oncology populations and emotional distress were assuming our patients were cognitively impaired. They weren't actually even testing to see if our patients were capable enough to go through their trials. And so at VCU at Live Now, we did a small study to just look at the basic cognitive screeners and see how many of our patients actually passed these screeners. 91% of our patients passed the same cognitive screeners that others were giving, showing that 91% of our patients should at least have been able to screen to participate in some of this research to learn if these evidence-based treatments are helping those with brain tumors. And then the other reason for exclusion that we find is treatment parameters. So the old, very old, thankfully, definition of survivor was off treatment. And unfortunately, our patients, a lot of our patients never are able to obtain off treatment. They're on some kind of treatment throughout their disease trajectory. So they were automatically being excluded. That definition of survivorship has faded away. Thankfully, we know that the day of diagnosis, our patients become survivors and thrivers. So we are debunking that one. Okay, so what I want to do now is I want to give you an example of the research that is being done to help the psychological distress of our patients. So there is a brief psychotherapy called Managing Cancer and Living Meaningfully. Its acronym is CALM. It was actually developed by 2 psychiatrists up in Toronto, Canada, the Princess Margaret Cancer Center. They have spent the last decade researching and speaking with advanced oncology patients to see what areas of distress are most meaningful to you and where do you need the support. And they came up with a brief, like I said, psychotherapy. It's a talk therapy that focuses on 4 domains. The first domain is symptom management and how to better communicate with your healthcare providers during treatment. The second domain is the changes that happen in personal relationship, not only with yourself, but in those that you love after a tumor diagnosis. The third domain is spirituality and finding a renewed sense of meaning and purpose following a tumor diagnosis. And the fourth domain is looking at the future and trying to balance having hope, but also knowing that we are diagnosed and some of us battling an incurable disease. And so finding the balance of both of those realities in the day-to-day. So like I said, they've spent the last decade creating this intervention specifically for oncology patients. In their very large randomized control trial, which is basically where they have a whole bunch of people go through the intervention and they see, is it doing what we're hoping it to do? They had over 300 people enrolled in their trial. They found that it reduced patients' depression, and it's the only intervention to date known to reduce death anxiety. So when I found this, I was thrilled. I flew up to Canada. I underwent the training. And through all of the learning and presentations, I'm noticing I'm hearing breast cancer, I'm hearing lung cancer, I'm hearing kidney cancer. I'm not hearing anything about brain tumors or brain cancer. And so I raised my hand and I said, well, what are the effects for those that have brain tumors? And not surprising, given the statistic I just showed you in the previous slide, brain tumors were purposefully excluded. And so, of course, with respect, I raised my hand and I asked why. And they gave me all the reasons that I just explained to you why others are excluding our patients from these interventional trials. And so I raised my hand again and I argued. I said, I have been working in this field for years. I feel that our patients can participate. I feel that they would benefit from this. And through some interaction, they agreed to partner with me. So for over a year, I trained in this intervention and brought it to the United States. So we received a small grant from the American Cancer Society, and we looked at CALM, this intervention. Again, it's a brief intervention. It's 6 sessions. In a small sample, we had 12 patients with malignant glioma. And we found at the end of the 6 sessions, 100% told us that it was beneficial. 100% said they would recommend CALM to others that had brain tumors. And if you can see this graph on the right-hand side, the PHQ is a questionnaire that we use to measure depression. And the DADS, the Death and Dying Distress Scale, is a questionnaire we use to measure death anxiety. And what we were seeing were the same benefits. In our brain tumor patients, depression scores were going down and death anxiety scores were going down. So that started to give us, okay, we can do this in our patients with malignant glioma. Next, I wanted to look at, can we do this in our brain met population? Because again, they are experiencing very similar effects, having tumors that have spread to the brain as our primary brain tumor patients. We received funding from the Department of Defense. We ran 15 brain met patients through the CALM intervention. So again, 6 sessions of one-on-one individual therapy. We saw very similar results. 100% described CALM as beneficial. 100%, all of them said they would recommend CALM to other patients who had brain metastases. And we are seeing that same reduction in both depression and death anxiety scores. So that gave us the green light, and my shameful plug right now that we have moved on to the next phase, a phase 2 trial of CALM in both our primary brain tumor and our brain mets population. We are trying to enroll 60 patients to undergo CALM therapy to help reduce that depression severity and the death distress severity that is so common. Again, over 50% of our patients are experiencing these levels of distress. The great news about this is an all telehealth intervention. And so we are able to provide this care to patients not only in Virginia, which is where I am housed, but anywhere in the United States. We have patients from Texas, from California, Portland, Oregon, Massachusetts, New York, Florida, that have joined and enrolled and are participating in the CALM therapy because they aren't able to get those resources or haven't found them in their home institution. So again, we're taking that. Our patients have been excluded. Our patients are not participating, and we truly are adjusting that in the field. Us professionals, everyone you're going to talk to today, is ensuring that while we are trying to extend the quantity of our brain tumor patients' lives, we are also helping to ensure that their quality of life is also improved. So right now, like I said, we are hoping to get 60 patients. As of this morning, we have 37 patients enrolled. So we still have 23 slots, if my math is correct, left. If you are interested in this, if you are experiencing depression or death anxiety, please reach out to us. We are happy to screen to see if you meet eligibility and can enroll and participate in this with us. I have put down our recruitment email. It's our lab email, livenow@vcu.edu. You can also give our lab a call. Look us up on Twitter, any way to connect. Happy to see if you could also undergo the calm therapy. That is just one of the many things that myself and the other colleagues that you'll hear from today and the ABTA are doing to help support the quality of life of our patients. So I'm going to wrap up my presentation by reminding you that you're not alone, that a brain tumor diagnosis can impact emotional health. There are things that you today can directly do to help support your emotions. But there are also people out there like the ABTA that want to help, professionals like myself, professionals like Dr. Castro that can direct you to services in your local area. And while I could sit here and speak for hours about what my patients have shared with me and what my research shows, I think there's no better way than to hear it from a thriver themselves. So I would like to introduce you to one of my patients and one of my friends, Ashlee Smith. Hi, Ashlee.
Hi.
How are you?
I'm good. How are you?
I'm wonderful. Thank you for being here with us today.
Absolutely.
I'm so excited for everyone to hear your story and hopefully have a glimmer of hope for everything you have been through.
Absolutely. Happy to be here.
Great. So let's start by, why don't you tell us, introduce yourself, tell us about how you found out that you were diagnosed with a brain tumor, and what did that feel like? What did you experience at that time?
Yep. So I am also in Virginia with Ashlee. I am 44 years old. I got diagnosed 4 years ago. So 4 years ago was right at the start of COVID. So we had just left work from home. I was working from home for about 2 months. I started getting massive headaches. I started slurring my speech. I couldn't find words. And I attributed all of that to working from home, being in front of a computer, being isolated, and just kept blowing off all of these symptoms. And then one morning, my husband came in and said, "You're going to an urgent care." He heard all of my symptoms and put them all together and said, "Something's going on." Basically, my husband saved my life, just so you know. And so I went to urgent care and I didn't think anything was happening. I thought they'd just say, take some Tylenol and, you'll feel better in a couple of days. But something I said, something triggered something in the doctor I saw. She sent me for a CT. And then the CT came back with something. So she said, you have to go see a neurosurgeon. So I did. That night I went in and saw a neurosurgeon, and he looked at my CT and said, "Okay, you need an MRI." And that was a Wednesday night. And so Thursday morning I had MRI. He said, "You need surgery." And I said, "Can I go home and talk to my kids?" Because this was such a blur. I needed to get home. It was also Father's Day weekend. So I just wanted some time to kind of breathe. So I got a lot of pushback on not leaving the hospital for 3 days over the weekend. He finally allowed me to go home. I got to be with my family. But I had these massive headaches that I wasn't really internalizing any of this. I just thought, all right, just do what the doctor says and I'll be fine. So at this point, I still never thought it was anything serious. Monday morning, went in, had the surgery. And apparently in recovery, I still was out of it. The neurosurgeon said it's not good. But I do not remember that because I was, again, totally out of it. I went back after they did the pathology and I went to see the surgeon again about a week later. That was when it hit me, when he said, "You have glioblastoma." So that was hard. Never thought for a minute that I had cancer. I'm active, I'm young, constantly moving. I was a fitness instructor and all of that. So it made it really, really hard to digest. And of course, I did something I shouldn't have done. I went to Dr. Google and saw the prognosis of a GBM, and I lost it. Like, that's where I went downhill. Was very, very difficult to move on from that.
What do you mean? Tell me a little bit more about you lost it. Like, what does that look like?
The fact that the prognosis was so bad that I wouldn't see my 9-year-old daughter graduate high school. I wouldn't have a life. And I had so many plans. Being 40 years old, my life was like halfway over, maybe, not even.
Right.
And it was devastating to see that, which I know I shouldn't, but I didn't have a lot of facts at that point. And I was just debilitated. And plus recovering from brain surgery and, all of this other stuff, put it all together, I couldn't get out of bed. Like, a lot of the depression you were talking about, that's where I was. I just stayed in bed. I took my medicine. I laid in the dark because the light was hurting my head. Like, I was rock bottom is really what I was. So you kind of just let it be for a while because you're just fresh out of surgery. So anyway, my first diagnosis reaction was depression.
Yeah.
For my quick summary of where I was.
Well, and I think, one of the positives about virtual is that we have so many people that can join. One of the negatives is that we can't see the attendees, but I have a sense and a feeling that there's a lot of head nodding going on, that other people, again, living their life, doing everything right, like you said, working full time, taking care of your family, exercising, eating right. You were the epitome of health. And then wham, all of a sudden symptoms come on and you're handed this very heavy, traumatic, shocking, if I can use those words, diagnosis that sent you into a spiral.
That's right.
So you said you are 4 years out of diagnosis.
Yeah, it's the end of June will be 4 years
since
amazing. My GBM diagnosis.
Yes, amazing, which is why I always call you my rock star and a thriver, right? You're not just a survivor, you're a thriver. Tell us about the 4 years. Tell us, is there anything else in my presentation or the discussion of emotions that spoke to you? Have there been highs? Have there been lows? Tell us about the roller coaster that I hear from my patients.
The scanxiety. I can never say it. That was very spot on. Since you have scans every 8 weeks, the week before, the week of, the day of, I was a mess. I was so stressed out. Just didn't even know what to do. And then the scan would come back great. And I'm like, whew. And it felt like I lost 10 pounds off my shoulders. Like, it was a huge relief to see the results, but going into there, it was tough. The other thing about me was, before my diagnosis, I am a control freak, a type A. I have to be in control. So I've worked with you a lot on understanding. The big thing I changed about myself is you can never be in control of everything, right? And having cancer is definitely something you cannot do anything about, right? Like, it's there. So I've worked a lot, really hard, to be accepting of you can only change things that you can control. Like, other than that, like, you got to just be with it, be okay with it. I have a sticky on my mirror for 3 years that says flip the script. So if I start feeling down or I get frustrated with something that's going on I can't control, I have that sticky. Like, so that's kind of my mantra. Flip the script. If I start feeling depressed, start getting stressed, start feeling out of control, that's my mantra. So I keep using that. That helps a lot.
I love that. I think that's powerful, beautiful. And I love that you're incorporating things into your day to day, because you don't know what today's going to bring and what emotions you're going to be feeling.
Right. And it even helps outside of just the cancer part of my life, right? Like,
I think that is such an important part, Ashlee. And I talk to my patients about this all the time. The tumor diagnosis, a cancer diagnosis, is just one aspect of your life. all the other typical stressors that are involved in life don't go away after a brain tumor diagnosis. So it is a piece of your life. It is a chapter in your trajectory, but you're also still dealing with everything else. And a lot of these mental health strategies that we talked about, and it sounds like you're, incorporating, can be helpful for all the different stressors in our life.
Yep, exactly.
Is there any other is there any other strategies other than flipping the script, that sticky note to remind yourself the mantra that you've used that have helped? Is there any that you found that wasn't for me? Because that's totally normal too.
I tried the meditation. I've tried yoga. I am not a yoga person. But the breathing and like the calming definitely helps, especially I have trouble sleeping. I have for years, even before my diagnosis, that when I wake, I can go to sleep just fine, but I wake up in the middle of the night and I can't go back to sleep. The breathing definitely helps to calm my mind because my mind starts racing. So using the breathing techniques, using some of the, what's the word? Picturing something that's bothering you.
Guided imagery.
Yes. Where if something's running through my head and it's not a big deal, I actually put it in a box, put it into the river and watch it float away.
Yes, the flow stream.
Yeah, it kind of sounds funny. When you told me about it, I was at first like, that's kind of crazy, but it actually works, especially in the middle of the night when I can't sleep. Definitely helps.
Take 1 minute and describe that to the audience members, what the flow stream is.
So I tend to have a lot of running thoughts in the middle of the night. And when I can't sleep, I think about those and I put them into a virtual box in my head and I fill them all up. I put it actually in a river and I watch that thought and that box float away. And it actually helps calm me. And it lets my mind kind of calm too, that I don't have to worry about it right now. It's like I said, it sounds kind of silly, but it does work.
Wonderful. I love to hear that. Thank you for teaching that to our audience members. I bet you a couple people are going to go away with that tool now.
Yeah.
If you had one piece of advice for somebody that was either just diagnosed and or somebody that's 4 years out like you are, what would you say to them?
I would say, make sure you have people in your life that you can talk to, especially about your cancer or about anything else bothering you. I actually found a friend of a friend who had just gone through some brain cancer treatments. So he was like a year ahead of me. Okay. And we actually became really good friends. We've met, so having like almost like a mentor, definitely helped me to not like talk to my husband every time I had a question or something, every time I had stressing. I didn't want to go to family every time I had an issue. So to have somebody more neutral, somebody who also understands exactly what you're going through, was really helpful for like a mentor or just a third party, even that's very engaging and that really wants to work with you. Just hear your thoughts, let you vent to them. I do think that's a great thing to make sure you have.
So it sounds like that program that Ralph was talking about, the ABTA program, where the mentor-mentee could be really helpful.
Yes.
And if I remember correctly, you didn't initially do that. It took you a while before you reached out.
Or would even talk about my issues.
Right.
My diagnosis.
Right. Yeah. So that's common too, to not be ready yet. But it sounds like in hindsight, that is one of the things that has helped you the most.
Yeah. I mean, even if you find one person, like you don't really want to talk to everybody and tell the world about where you're at and what you're feeling and what your diagnosis is. If you can have one person like that's your person to kind of work with on your feelings. It doesn't have to be a professional. It doesn't have to be your doctor. It doesn't have to be family, just somebody in your life that really lets you be you and helps you through some of the tough times.
Yeah. Not being alone.
Yes.
Yeah. Ashlee, I can't thank you enough. You are the true definition of a brain tumor thriver. And I know that everyone has learned as much as I have from you. Thank you for participating and helping.
Thank you very much for having me.
Of course.
Thank you so much, Ashlee, for the courage to share your story with all our patients and caregivers today. It was wonderful to hear about your experience, and I'm very glad that you have connected with Ashlee and you're getting terrific support from her. And thank you so much, Ashlee, for a wonderful presentation. You hit all the highlights there, and we have a number of questions that have come through the Q&A, and we'll try to address as many of them as possible. And I'll just start with the first one here. We'll follow the order. Do caregivers experience the same types of anxiety, such as hypervigilance?
Yes, the answer is 100% yes. And again, our research shows they actually experience it higher. The hypervigilance, I have caregivers that will come to me, not even to the patient, and say, Joe had 3 times yesterday that he couldn't find his right word. Is the tumor back? And they have higher distress levels, higher anxiety levels than the patients themselves.
Thank you for sharing that. And obviously an area of great need also, the support of caregivers.
Yes.
I want to acknowledge one of the attendees who is, nodding to your recommendations about exercise and connecting with friends and family. What are the pitfalls of moderate alcohol consumption on symptoms of depression and anxiety, particularly for those who have consumed alcohol moderately their entire pre-cancer life? What are your thoughts on that?
I mean, alcohol is a depressant, right? So it is used as a immediate coping, but long-term it is not favorable for our mental health. And so, unless your physician has told you no alcohol consumption, I'm not going to say that, but it should always be done in moderation. You should always talk to your physician about it prior, because there are some medications that our patients are on that actually are contraindications with having alcohol. Social alcohol use, one beverage, every once in a while is not going to hurt you, is not going to throw you into clinical depression, but moderate to severe use is putting you at risk for experiencing symptoms that you're already at risk for having a brain tumor. That's a great question and not talked about often.
I agree 100%. And that's my recommendation to patients too. Only moderation. Right. In reality, we're coming to learn that there's no safe drug, no safe dose of alcohol.
Right.
Right. So, I think,
and I try not to remove every vice from people's lives. Yes. I tell them, I say, if you want an ice cream, have an ice cream, but don't have an ice cream for every meal. Right. So
exactly.
If you would like a social beverage because it's an event and your doctor says it's okay, that's okay. But, daily use, moderate to severe use is not going to be beneficial.
Certainly. The next question is somewhat related. Does THC, tetrahydrocannabinoid, have a role in managing mental health symptoms without some of the side effects of antidepressants? If so, is there a way to manage THC-induced cognitive impairment other than timing on patients who already are experiencing cognitive impairment? A very important question.
Very important.
Love to hear your thoughts.
Yeah. So some of it is above my level just because I don't research THC. A lot of our patients, especially now that it is becoming legalized or decriminalized, are using THC to lower their stress, to help with their anxiety. They are reporting great benefit from it, but there are some negative consequences, right? There are some negative effects. It does cause slowing of the brain. In fact, when we cognitively test our patients, they have to be off of any kind of marijuana or THC use for multiple days before I will even test their brain, because I won't be able to tell the effects. And so it is going to contribute to the slower thinking that our patients are already experiencing. However, research is showing some added benefits on the mental health side, again, used in moderation. And of course, always be open and honest with your physicians about what you are using as coping mechanisms, whether that be alcohol or THC.
I agree 100%. We have some questions about, rumination, or I interpret them as related to rumination, which is, going back over the same thought and not being able to escape that loop. And we have a participant that was asking about, flipping the script, what you mentioned, Ali. And are there any other strategies that you follow, any positive encouragement that you give yourself when you look at yourself in the mirror?
Yeah, it's really just the take things one step at a time as opposed to letting things spiral. That's another one that I definitely tell myself in the mirror and a lot. And that whole you can only control what you can control. I mean, for me, that's huge because especially with a diagnosis of cancer, you can't control that. So you have to really be okay with yourself not having control. And I struggled with that for a long time.
Some of our patients benefit from what we call worry time, which is designating a certain time each day that they will allow their brain to spiral or ruminate. And if they catch themselves doing that outside of that block of time, some people in the morning, afternoon, we say try not to make it too late at night because it can impact your sleep. But if they find themselves outside of that time beginning to spiral or ruminate, you use distraction. You find something else to direct your attention on and focus on, and then you bring that back to your mind during that time. And again, a lot of times 5, 10, 15 minutes tops is what we'll say. Allow your brain to go there. These are natural, valid thoughts that a lot of times you are having, but we can't live our life in those thoughts. So allowing for a certain allotted time, and then outside of that time, distract yourself with things you like, people you enjoy, getting outside, all of those basic mental health strategies.
Yeah, and I would do a little bit of that as well. Like I would have cry time, like just go in your room, let it all out, and then I would feel better. So that's like another thing that you can do is just take that time to acknowledge it. You don't want to keep pushing it down. You want to acknowledge.
Right. And in the mental health world or psychology world, we will say, pushing it down actually makes it bigger. It's putting your energy on it, right? And we can push it down as much as we want, but it doesn't make it go away. So eventually that closet's going to burst open or that bag is going to pop, and we're going to have to deal with it. It is okay to feel these emotions. These are valid, normal emotions. It is just learning how to make sure we manage them so that we can still live a meaningful, full life while having these emotions.
Thank you both for your perspectives. We have a few questions about the CALM study, which is a wonderful study, and I have referred many of my patients to participate, and I've heard wonderful things in terms of their experience. Patients are asking about the inclusion criteria and the possibility of having patients with meningiomas, for example, to participate. Is that a possibility?
Yeah, this is a great question. Thank you for whoever asked this. So our inclusion criteria right now is any kind of brain metastasis. For primary brain tumor, we are just doing malignant. So anyone grade 3 and grade 4 for now. It is possible in the future we will open it up to low grade, but for right now we're just studying the ones that are high grade, the cancer diagnoses. So meningioma would fall into that group if you were diagnosed with a high grade meningioma, so grade 3.
I see. So high grade tumors, including high grade meningioma, are able to participate, and Ashlee shared an email there to connect with them if you're interested.
Yes.
We have questions about supporting caregivers, and the questions are: how can survivors help our caregivers, or how can patients support caregivers? What are your thoughts on that? Maybe Ali and Ashlee.
I really think that you have to kind of give them breaks if you can, right? Like I don't have a lot of deficits from my surgery and all of that. So I allow my husband to take a break, to go on runs, to, even if I couldn't do anything, I would make sure that I was safe and I was laying on the couch or whatever, and make sure that they can do what they want to do to get a break. Kind of like all the things that Ashlee listed for the patients, go out for a night with some friends, let them go. And then I would think if you can't be home alone, depending on how you are, have somebody come over with you and let your caregiver get a break. Try to talk to them also and see how they're feeling, how they're, really, we had some deep conversations on my diagnosis, on my longevity. I mean, we had like really, really deep conversations for both of us, as opposed to just me keeping, I didn't want to bother him, so I didn't want to make a big deal of it. But, have those conversations as well. So that way it's almost like a closer relationship if you have some of those deep conversations with both of you.
Yeah,
Thank
I
you.
completely agree, Allie. I tell the caregivers all the time, in order for them to be a great caregiver, which is usually their number one goal, they have to take care of themselves. They are not going to be a good caregiver if they are burnt out, overwhelmed, on all the time. Nobody can do that. And so I encourage them, get out. If they can, have other people come over to be with the patient. It helps the patient and the caregiver, even if it just means the caregiver can go to the grocery store by themselves, because trust me, that becomes something that's really wonderful for the caregiver. And to ask for help. Everybody that loves the patient and loves the caregiver wants to help and doesn't know what to do other than the beginning to bring food. Once the food has stopped coming, ask for other things. Again, ask to come over and sit with the patient so the caregiver can go out for a night of fun or just go to the grocery store. If the patient wants to go to Bible study, see if there are others that can bring the patient to the Bible study, or even go to a doctor's appointment if the caregiver still has to work. There are many ways that we can incorporate the community that allows for reprieve for the caregivers, because it is very stressful and very draining.
Thank you for that perspective. And that answers one of the questions about, having only your spouse as being the listening ear or the caregiver. Trying to involve other friends and acquaintances is a helpful thing for the caregiver. We have a question about management of depression in older patients, 70 plus. If you have any specific recommendations in regard of helping those patients, Ashlee.
Yeah, I'm going to fall back on those mental health strategies. I tell my older patients, getting out of the house, being as social as possible. And it wards against the negative effects of memory loss as well. Actually, more getting out of the house, being social, and exercise more than medication does for dementias. So these are the same strategies that we would use for an Alzheimer's population in our elderly with brain tumors. Making sure you are using your brain and you are moving your body is the number one key to success to help with depression.
Thank you so much. There are a few other questions, and I think we have to go to a break, but I'll take a couple more. There's a patient asking about a difficult situation of managing separation or marriage separation during treatment recovery, and any recommendations about the stress on relationships and how to support patients and caregivers through this.
I mean, this is reality. I have experienced this with multiple of my patients where their relationships unfortunately unraveled throughout the disease or the diagnosis. And my number one recommendation is to seek counseling. Relationships are hard. Marriage is hard. And then you add the stress of a medical diagnosis and all the questions about the future. So I would do what, we had recommended before. Ask your doctor, your physician, is there anybody that you can recommend either for us to join as a couple? And this can even be preventative, right? Like we don't have to enter into a counseling relationship already having severe major depression. It can be, what can we do to make sure this doesn't happen? What can we do to support our marriage and our relationship? And as you saw in the calm domains, it's one of the domains is purely around relationships and how they change after a brain tumor diagnosis or a cancer diagnosis. So seeking help, getting the support you need, allowing the caregiver to have respite, like Allie said, will help in those relationships. And communication is key, is number one.
We have a question about support groups for patients with epilepsy. That's also a great cause of anxiety for many patients. When is the next seizure going to happen? How is it going to limit me moving forward? Are you aware of any support groups for patients with tumor-related epilepsy, Ashlee?
I don't have any offhand that in our local area that I know of. I wonder if the ABTA might have any. I don't know if Ralph or Emily could speak to that. I do know the thing that I recommend to my patients that happens all the time is being diligent with their anticonvulsant if they're on one. Obviously, there are breakthrough seizures that happen. And again, that might be something out of your control. But a lot of our patients that end up experiencing a seizure again is because they've missed their medication for a day or 2 days. So it is one of the number one things cognitively that I recommend to my patients. If you do nothing else that I say, don't forget your medications. Figure out a way to ensure you take that anti-seizure medication, because it does help for the majority of patients to keep those seizures at bay. But I don't know of any ones. Honestly, I would Google it. That's what I would probably do with my patient. I would open my computer and I would Google and see if there are any specific. You might look up some epilepsy foundations. They might have ones that, again, the etiology might be different. The epilepsy or the seizures might be coming from a different cause than a brain tumor, but they might have support groups or some strategies that you can employ or join that could be helpful.
I agree with that. And many of our patients are managed by neurologists, and they, can refer patients to internal resources, either within, outside the cancer center, but within the neurology department, to help patients with anxiety related to epilepsy.
Yeah, and it's understandable. It's one of the hypervigilance symptoms. Any kind of sensory experience that might be an aura coming on throws our patients into anxiety of, is this going to happen? And am I going to have another seizure again? Does that mean my tumor grew?
I just want to repeat again, there was a question of the CALM study, including meningiomas, and that was answered earlier, that patients can participate in the CALM study with a high-grade meningioma. That's a grade 3 meningioma.
Correct.
So if that diagnosis is present, you can contact Dr. Loughan to participate.
Yes. And again, you can live anywhere in the United States. Everything is done virtually. So we are expanding our services.
Perfect. Well, thank you, Ali and Ashlee, so much for your time today. We're going to leave it there for now and take a short break, and we'll resume with our next talk in a few minutes. Thank you all. Stay tuned.
Thank you so much, Ashlee and Ali, for sharing with us today. And Ali, thank you so much for your vulnerability and sharing your experience. I just wanted to respond to that one question. We have support groups that are online on our website, abta.org. We don't have one specifically addressing seizures or epilepsy, but I think that's a great idea, Ashlee, to maybe contact the Epilepsy Foundation. I'm sure there are patients within those support groups that experience those symptoms, but we don't have one specific. But that's really good to note, and definitely reach out to the Epilepsy Foundation. But thank you all so much for your time today. And as Dr. Castro said, we're going to take a brief break and resume back here in just a few minutes, in about 2 minutes. So feel free to go to the restroom, take a drink, get a snack, and we'll be back for our next presenter, Dr. Sean Hervey Jumper. See you in a minute.